Good day, everyone. Today we are going to discuss cysts, specifically epidermoid cyst and dermoid cyst, which are very important topics in surgery and clinical practice. Let's start with the basic definition. A cyst is a pathological cavity that contains fluid, semi solid, or gaseous material and is usually lined by epithelium. This epithelial lining is a key feature because it helps differentiate a cyst from an abscess, which does not have a true epithelial lining. Now, let's move to the epidermoid cyst. An epidermoid cyst is a benign cyst that arises from the epidermis. It is lined by stratified squamous epithelium and contains keratin inside. This keratin is continuously produced by the lining cells, so the cyst gradually increases in size over time. To understand how it forms, let's look at the pathogenesis. Initially, there is obstruction of pilosebaceous unit, which can happen due to acne, inflammation, or minor trauma. Because of this blockage, epidermis cells get trapped within the dermis. These trapped cells continue to grow and produce keratin. Since this keratin cannot escape to the surface, it accumulates and forms a cystic cavity filled with thick, cheesy material. If the cyst becomes infected, it may rupture and cause inflammation, leading to pain, redness, and sometimes abscess formation. The causes mainly include blockage of sebaceous ducts, trauma that pushes the epidermal cells into deeper layers, and conditions like acne. The key idea is that any process that traps epidermal tissue inside the skin can result in cyst formation. These cysts are commonly seen in young and middle-aged individuals and are frequently found on the face, neck, scalp, and back, especially in areas rich in sebaceous glands. Clinically, an epidermoid cyst presents as a slow-growing, painless swelling. It is usually round, well-defined, and has a firm or cystic feel. One very important feature is the presence of a central punctum, which represents the blocked opening of the sebaceous gland. This is very useful clinical clue. The swelling is usually mobile over deeper tissues, and if the infection occurs, it becomes painful, red, and may discharge pus. Diagnosis is mainly clinical. Ultrasound can help confirm that it is a cystic lesion. Fine needle aspiration may show keratin material, and histopathology confirms the diagnosis by showing a cyst lined with squamous epithelium filled with keratin. Management depends on the symptoms. If the cyst is small and not causing any problems, it can be left alone. However, if it is large, painful, infected, or causing cosmetic concerns, the treatment of choice is complete surgical excision. It is very important to remove the entire cyst wall because if any part is left behind, the cyst can recur. If the cyst is infected, the infection should be treated first and then the excision is done later. Now let's move on to the dermoid cyst. A dermoid cyst is a congenital cyst that contains not only squamous epithelium but also skin appendages such as hair follicles and sebaceous glands. Because of these structures, the cyst contains hair, sebum, and keratin. The pathogenesis of dermoid cyst is related to the development before birth. During embryonic life, when different parts of the body are fusing, some ectodermal tissue may get trapped beneath the surface. This trapped tissue continues to grow and behaves like a normal skin, producing hair and sebum. These materials accumulate inside the cyst, causing it to gradually enlarge. The main cause is this developmental inclusion of tissue along lines of fusion. That is why the dermoid cysts are commonly found in specific locations such as near the outer corner of the eye, in the midline of the neck, or in the floor of the mouth. These cysts are usually present from birth, but they may not be noticed until later as they slowly increase in size, and they are commonly seen in children and young adults. Clinically, a dermoid cyst presents as a painless, slow-growing swelling, and it is usually soft to firm in consistency. The skin over it appears normal, and importantly, there is no punctum, which helps differentiate it from an epidermoid cyst. And these cysts are often located along the lines of embryonic fusion. Depending on their depth, they may be freely mobile or slightly fixed. Deep dermoid cysts may extend to deeper tissues. Investigations include the ultrasound for superficial lesions, but CT scan or MRI is very important in deeper cysts to assess their extent and to rule out any deeper or intracranial extension. Fine needle aspiration may show keratin and sebaceous material, and histopathology confirms the diagnosis by demonstrating the skin appendages within the cyst wall. Management of the dermoid cyst is complete surgical excision. It is important to remove the cysts completely without rupture, because rupture can lead to inflammation, and in deeper cysts, careful surgical planning is necessary to avoid complications. To summarize, both epidermoid and dermoid cysts are benign cystic swellings, but they differ in origin and contents. Epidermoid cyst is acquired, has a central punctum and contains keratin, whereas dermoid cyst is congenital and occurs along the fusion lines and contains hair and sebaceous materials. In both conditions, complete surgical removal is the definitive treatment. So remember, if you see a punctum, think of the epidermoid cyst, and if the swelling is present since early life and lies along the fusion lines, think of the dermoid cyst. Thank you.